Columbia Global Centers Mumbai, in collaboration with the Herbert Irving Comprehensive Cancer Center, welcome you to this webinar, Screening for Breast Cancer During COVID-19.
Hello, everybody. I'm Ravina Agarwal and a director of the Columbia Global Centers Mumbai. I welcome you all to today's panel discussion, Screening for Breast Cancer During COVID-19. This is the inaugural event for our seminar series, Screenings That Save, which is newly launched and focuses on the importance of screening practices in early detection of cancer. Building on Columbia University's extensive work in this field, we at the Columbia Global Centers Mumbai are actively committed to advancing cancer education and research in India and in the world. October is the Global Breast Cancer Awareness Month, and in countries around the world, it is observed to increase attention and support for knowledge, early detection and treatment of breast cancer. In today's panel, Screening for Breast Cancer During COVID-19, we'll talk about the challenges of delivering breast cancer care during COVID-19, and our panelists will elucidate measures that will help patients retain access to care in times of such crisis. Breast cancer accounts for 14% of all cancers in India and is the most common cancer among women. It is said that in India, one woman is diagnosed with breast cancer every 4 minutes, and every 13 minutes, a woman dies of breast cancer. When we compare the post-treatment rates in India and the US, only 60% of women who are treated for breast cancer survive for at least 5 years post-treatment in India, as compared to 89% in the US. Such high mortality rates can be attributed to the lack of awareness and delay in screening and diagnosis of breast cancer. The COVID-19 pandemic has posed unprecedented and daunting challenges to the routine delivery of oncological and supportive care to patients with breast cancer. Some early reports have even suggested an association between a history of cancer or its treatments and serious complications from COVID-19. Patient apprehension, anxiety, and distress, coupled with confusion among healthcare providers about the best choices to make for their patients, have been aggravated by this pandemic situation for clinicians. With healthcare systems prioritizing the coronavirus over treatments over all else, this leads to life-threatening delays in diagnosis and treatment. And identifying solutions for delivering effective cancer care with regards to screening and early detection practices is very essential. In today's panel, our distinguished experts will address the central challenges of delivering effective breast cancer care during COVID-19 and discuss remedial measures for overcoming these challenges. To begin today's session and inaugurate our Screenings That Save series, we will hear from Dr. Anil Rustagi, the director of the Herbert Irving Comprehensive Cancer Center at New York Presbyterian and Columbia University Irving Medical Center. He's also the Associate Dean of Oncology at the Columbia University Irving Medical Center and the Chief of Cancer Services at the New York Presbyterian Hospital. Dr. Rustagi is a world-renowned leader in the field of gastrointestinal oncology. He has multiple prestigious publications to his credit, and he has been recognized for his contributions with numerous awards. So welcome to you, Dr. Rustagi.
Thanks so much, Dr. Agarwal. I'll just make some brief introductory remarks. I've gotten the chance to learn more about the center that she directs in Mumbai when we met pre-COVID, and had the chance to read more about it, and really full of admiration for all that you and colleagues have accomplished there, as well as other colleagues in the other Columbia Global Centers. So in the context of certain diseases and disorders, the relationship between our medical school and medical center with the center in Mumbai is of great importance. And I know that my colleagues, Drs. Rao and Terry, visited your center pre-COVID. I think it was January or February, from what I recall. And I know that spurred additional interest, because when they came back, we had the chance to speak. So we thought today, based upon your recommendation, we would be speaking about cancer, specifically breast cancer. There's a lot going on in breast cancer, in not only recognition of Breast Cancer Awareness Month this month, but from basic biology to epidemiology to clinical care to clinical trials. We really cover the gamut, and I can't imagine two better experts than Dr. Rao and Dr. Terry. So thanks for having us. I appreciate it.
Dr. Rustagi, will you share a little bit more about the Herbert Irving Comprehensive Cancer Center for our audiences?
Sure. HICCC is the abbreviation, what's called an NCI designated cancer center. In 1971, the President and Congress signed a bill for the War on Cancer Act. And Columbia is actually one of the originally funded cancer centers through that mechanism. And then 8 years later, in 1979, Columbia achieved what's called comprehensive status, which means runs the gamut from basic science to population health and everything in between. And that is something that is accorded to a little over 50 cancer centers in the United States. And then we, through a lot of hard work and credit to many people, we had that status renewed for 2020 to 2025 with the funding that goes with that. We really are a university-based center with 180 members and 40 associate members, spanning 35 departments and 6 schools. So we interact a lot also with School of Arts and Sciences and School of Engineering, besides our 4 health professional schools. And then in turn, we have 4 programs which span basic science to population science. And then we have an infrastructure to support that structure. One of the critical infrastructural components is headed by Dr. Terry, what's called the Office of Community Outreach and Engagement, and she'll talk more about that. So, and then, you know, clinical patient care at the end of the day is most critical to us. Research is a big component, and Dr. Rao oversees breast cancer surgical oncology. But we have, you know, multidisciplinary approaches to cancer care. Most of our patients are from New York City, but also from New York, Long Island, New Jersey, but we have patients from all over the world, and we actually have a service to help facilitate that. So if there are patients from Mumbai and other parts of India that need our advice and input through telemedicine, we can provide that. If they do need to come to New York City, we can provide that as well.
Thank you so much, Manisha and Dr. Rustagi. This idea germinated on focusing on diagnosis and screening. We had a conference in December. Thanks to the Yusuf Hamid Fellowship Awards, we were able to host that in conjunction with the Mailman School of Public Health, and Dr. Terry and Dr. Rao were present at that. And we heard something very moving and disturbing, where one of the doctors shared about how they never see breast cancer patients before stage 4. And that was, chilling to us. And we realized how important this issue of screening and diagnosis is in our conversations. And thanks to you, we were able to put this series together, starting with this one. So we look forward to hearing from our panelists, and Manisha will now invite the panelists and introduce them.
Thank you, Dr. Agarwal. Thank you, Dr. Rustagi. Our first speaker for the day is Dr. Roshni Rao. Dr. Roshni Rao has been the Chief of Breast Surgery at New York Presbyterian since October 2017. She's also the Vivian L. Milstein Associate Professor of Surgery at Columbia University. Her research interests include techniques to optimize breast operations, management of the axilla and breast cancer, and individualized assessment of the risk of triple-negative breast cancer. She has numerous publications to her credit. She currently serves as the chair of the American Society of Breast Surgeons Patient Safety and Quality Committee, and is a member of the editorial board of the Annals of Surgical Oncology. Over to you, Dr. Rao.
Thank you very much. I appreciate Ravina and Manisha putting this together. I think it's a very exciting event, and I think it's really important when everyone's attention has been so focused on the pandemic that we not forget that there's a tremendous number of patients who still suffer from breast cancer, and that we need to continue the advances that we've made in that field as well. So thank you for making sure that we don't forget about this other aspect of our lives. I'm going to focus this talk on, to some extent, what happened within New York City as we went through this pandemic, and what we were able to accomplish when we pulled patients together and our physicians together and found a way to make this work. So my outline, I'm going to go over kind of the rapid evolution about how things occurred. We're going to go over are the components to a response should you find yourselves in the midst of a pandemic trying to take care of breast cancer patients. And all these components include multidisciplinary discussions, telehealth, communication, resource conservation, and I'm going to go over some of our data that occurred with that. And then finally, I'll give some summary thoughts about what we've learned during this time period. So how rapid the response occurred and how rapidly we became to some extent overwhelmed by the pandemic, I think many people are familiar with. But on March 3rd, we had our first case in New York City that was travel associated. On March 4th, one day later, we had our first patient within our hospital that was the first case of person-to-person spread. And on March 13th, literally 9 days later, we canceled our elective schedule. And this occurred because our hospital started to fill with COVID patients. Columbia has 120 ICU beds on a regular day. We ended up needing at the peak 300 ICU beds. And it's not only the beds, but all the people who you need to take care of those patients. And so in response to that, our caseload was entirely canceled. And these are patients who were diagnosed with breast cancer 3 or 4 weeks ago, were put on the schedule, waiting for their operation, and we called them on Friday afternoon to say, you know what, your case has been canceled, and we really don't know when we're going to be able to get it back on. And on March 16th, all of our restaurants in New York City closed. So anyone who's been to New York knows how important that is a component. And for those of us who eat out 4 or 5 times a week, it's an important component of just being able to live. So everything got canceled. Our approach included a really careful multidisciplinary discussion. As a rule, we have a tumor board every Monday. You can see that there. It's a pretty good sized group that's packed into this conference room. We have review of our complex cases. We also have one of our satellite locations join us virtually, and it includes radiologists, medical oncologists, radiation oncologists, surgical oncologists, pathologists, and geneticists, which are able to discuss all of these cases. And it's a very important part of making sure that we're very thoughtful about all that we do. When we started bringing in the COVID patients, that conference room, in fact, ended up being a call room, and we were able to, like a lot of academic centers, transition to an entirely Zoom platform. This was remarkably easy. Muting is, of course, the key, and everyone slowly learned this over time, that unless you see that little red microphone, everyone can hear exactly what you're saying. It allowed the continued discussion of complex cases, and it also allowed us to discuss the delays and how we were going to approach this, again, in a multidisciplinary fashion. And our platform for our tumor board has continued on Zoom and will be that way for the foreseeable future. We utilize the Epic platform for our electronic health record. This platform, we've had access to telehealth for about a year. We had exactly 0 visits in the year prior to the pandemic. And over the 3-month period of the pandemic, we had 77 visits conducted via telehealth. And there are 5 patients that we operated on who the first time we met them in person was actually in the pre-op holding area. So this is not optimal, because if you found something on exam or identified some other problem, we would have had to cancel those patients. But for those 5 patients, it's what ended up working. So it can be done for these carefully selected patients. Communication was key to all of this. Columbia has 32 operating rooms. All of them were converted to what we call ORICUs, operating rooms that had intensive care unit patients within them, all of them COVID patients. So we only ended up with 4 operating rooms that were functional. And that required us to create a committee that sat down and reviewed all of the cases from all of the services, cardiac, neurosurgery, colorectal, all of our cancer patients, to try and sort out which patients were appropriate to have their operations within one of those 4 ICUs. And this committee met every Saturday. They reviewed the cases, and then they informed us which cases were able to go. So again, these are cancer patients that we're saying we're going to submit you on Saturday, and you might or might not have surgery the next week, but be prepared in case you get approved. And so consequently, what our division did is that every Friday, we had a triage conference that included our administrative assistants, our nurses, all the physicians. We had all 150 patients that had been canceled on a spreadsheet, and we were able to go through them and sort out which ones were really critical to go to the operating room, particularly patients who had just finished neoadjuvant chemotherapy, and we had a very short window in which to do their operations, patients who had very critical pathology questions that only surgery could determine. So we were able to put those 4 or 5 patients in for submission and then figure out if they were going to be approved to have their surgery the next week or not. We came up with a very rudimentary approach about who could go to neoadjuvant if patients' tumors were sensitive to hormones or endocrine therapy. We offered them 12 weeks of endocrine therapy as a bridge to surgery. Patients who we knew were needing chemotherapy went on to chemotherapy first. The minimum chemotherapy that we needed to do, that was from an immunosuppressive perspective, and then we're able to get the patients on as they opened up the OR. One unique thing that we did do in conjunction with our radiology colleagues, for patients who have tumors that we cannot feel, who we cannot palpate, those patients require some sort of localization before the OR. Traditionally, we have done that with a wire. So a wire was placed on the day of the operation, and we would be able to schedule them. All of our mammography, as well as our radiologists and our technologists, were redeployed to other areas. So we took all 150 of our patients, determined who needed localizations, and within 1 week, every single patient that needed a localization, instead of a wire, got a Savi scout. And so this is a device that can be placed many months before the operation. It's approved for permanent implant, so if it doesn't get removed, it's okay as well. But all of these patients got their Savi scouts placed within 1 week, with the idea that if we got approval from the OR, we were immediately able to get them on the schedule, rather than trying to find some way to do wire localizations when we had such minimal resources. We're able to pull together our data, and you can see that normally we perform about 150 cases. We performed a little less than 50 during that 12-week time period of the pandemic. The distribution of the cases was fairly similar. Our operative time significantly increased, and that's likely a function of just having different teams that we normally did and having to pull together equipment and things in ORs that are not traditionally used for breast surgery, since we were down to those 4. We also evaluated our outcomes. We looked at hematomas, seromas, return to the operating room, emergency room visits, and we really found no difference. Interestingly, we were performing a lot more ambulatory surgery during this time period. So patients who traditionally we admitted mastectomies with reconstruction, those types of cases, we were in fact sending them home with very specific teaching and education, and we were doing telehealth visits with them the next day. It's something that we would not normally do, but it worked. And in fact, the patients were very accepting of it because they wanted to recover at home rather than be in a hospital where there was such a COVID influx, if you will. We were able to put this all together in a manuscript that just got published in the Annals of Surgery. And as we think about this, should your division have to deal with a pandemic and having to provide cancer care during a pandemic, these are all the components that you have to think about, how you're going to triage patients. The multidisciplinary discussion was key, incorporating telehealth and being able to utilize the OR as it comes along, even if that involves some changes in your processes. So my summary comments, delays of 3 months may be necessary for some patients, but if this is done with a multidisciplinary approach, utilizing endocrine therapy and potentially chemotherapy as a bridge, it can be done safely. Acute cases can be managed in the midst of a pandemic as well. There has been no case of patients who had their operations during this time period who contracted COVID during their surgical time or during their time in the hospital. And utilization of telehealth, video conferencing, as well as novel technologies is critical as you think about how to be able to take care of this patient population. That's the manuscript. So I want to thank everyone for their attention. This is from our visit to the beautiful Columbia Global Center in Mumbai. It certainly seems like a lifetime ago. No masks, and certainly no social distancing, but a really wonderful place to visit when we get a chance to see each other again in person. Thank you very much.
Thank you. Thank you, Dr. Rao. Our next panelist is Professor Mary Beth Cherry. Professor Mary Beth Cherry is Professor of Epidemiology and Environment at Columbia University. Her research interests include cancer prevention with a specific focus on breast cancer. She's a cancer epidemiologist with over 20 years of leading studies of cancer etiology. Dr. Terry currently leads NIH grants funded through the National Cancer Institute and the National Institute for Environmental Health Sciences that focus on following cancer risk within family-based cohorts focused on studying environmental exposures during key windows of breast cancer susceptibility. She's also leading prospective studies to validate and extend breast cancer risk assessment models. Professor Terry?
Thank you so much. I'm an epidemiologist, which I think now everybody in the world knows what an epidemiologist is. So I'm not a medical doctor, and if there's any medical questions, please refer to my colleague, Dr. Rao. But I'm very thrilled to be here on the topic of screening, because essential to a discussion about screening is really to understand the epidemiology of the disease. So we also, in addition to epidemiology, now the world has been exposed to this concept of a pandemic. A pandemic is multiple epidemics across multiple countries, across multiple continents. And if we use that definition, we can see that the shape and nature of breast cancer has changed dramatically over the last 2 decades, and really stands out as almost, well, certainly on every continent, there's countries where this is the #1 cancer in women. So when we look a little closer then at the rates in India, as you know, and I've used 2 different sources here, GlobalCon data and GXDX data, which are slightly different in how they pull from different areas of India. What you can see very dramatically is since the early 80s, this increase in overall incidence, as well as an increase more dramatically even over the last 10 years in mortality. The National Cancer Institute in the United States defines an epidemic of a cancer as being anything more than 1% per year. And in India, and certainly many parts of the country, many parts of the world, that definition of an epidemic is true for breast cancer. And these rates, as I'll go through in just a minute, are way above 1% per year increase. So when we look a little closer then at the age groups, here at the top, cancer, as you know, is a disease of aging. And of course, the incidence rates on an absolute scale are highest in older individuals, but they are still increasing in every age group. So again, here are the 2 different sources of data. At the top here that I'm highlighting are in women over 70. The middle 2 bars here are in women 50 to 69. But in women too, under 50, the increase has also been rising quite a lot, even though the absolute rates, so the number of women under 50 are still much lower than older women, the rates are increasing across all groups. And also you can see the increase in mortality across the 3 age groups. So another area that has been very much happening in India has been this shift towards younger women. So this was a publication. The red bars here indicate current proportion of cancers, breast cancers. The blue bars represent about 25 years ago what happened. And again, this is not looking at rates, it's just looking at proportions of cancer. What you can see is that there is this skew towards younger women. So yes, cancers are resulting from aging, but the shift of the distribution of cancers to young women in India is a really a very disturbing trend, because again, cancers in younger women tend to be more aggressive. They tend to be what we call triple negative breast cancers, which is estrogen receptor, progesterone receptor negative, and HER2 negative. So you can see here, there is this shift towards younger women. So the increase in breast cancer in India is not just because of an aging population. There really is this shift towards younger women, which has implications for screening. So when we think about reducing incidence and mortality of the disease, reducing incidence would mean reducing exposures to the risk factors that we know of for breast cancer. Reducing mortality would mean screening. And as Ravina said at the very top, what was staggering when we were at the Global Center and had a panel of experts from India, what was staggering was just how many cancers get diagnosed at a very late stage. So what can reduce that is breast cancer screening, and that's what we're here to talk about today, and the feasibility of doing that. So again, just to think about how much has changed in recent years. Here on the x-axis is starting back in the early 80s, going all the way up to just a few years ago. And here what I'm comparing are the incident rates on the left-hand side to the US. So in the early 80s, there was a 4.5-fold difference between the rates of breast cancer in the US and the rates of breast cancer in India. And what you can see here is there's been a steady decline, a pretty dramatic decline. The rates of breast cancer are still much higher, 2.5-fold, excuse me, but it's still a pretty dramatic difference. And again, through the other source, you can also see that that decline has been happening over the last several decades. So this really means that this is an important time to be thinking about how we can identify women earlier and improve outcomes by shifting the stage distribution. So in terms of thinking then about the mortality rates, if we were to go back to the mid-90s, again, on top here would be a comparison of the US-India mortality rate. So, as recent as 1995, it was close to a 12-fold difference in mortality rates. And now you can see it's gone down quite dramatically. It's still very high, but again, it's gone down very dramatically. And then the under 50 rates are pretty close now to 1. So that what that means is the mortality rate. So again, the mortality rate is going to be the number of deaths per 100,000 women. The mortality rate is very similar now between India and the US. So that also is something that we should think about and discuss. So in terms of thinking about how to reduce breast cancer risk, again, it would be twofold. So we, in the community, as Anil mentioned, we do a lot of outreach. We think about things that you can do throughout your life, and one would be to lower kinds of exposures that could improve outcomes. We do know that breastfeeding actually does have, across all molecular subtypes of breast cancer, very important role to play, even in triple negative breast cancer. So the estrogen receptor, progesterone receptor cancer. So the more a woman breastfeeds, the lower the risk is. Regular exercise, limiting smoking and alcohol, and also maintaining a healthy weight, particularly after menopause. All of that helps. But when we think about screening, again, really given the shifting of the age and early onset, really that's seen across many countries around the world, we have to think about ways to improve how we identify young women. And mammography, as you know, is a wonderful screening tool. It is sensitive the younger you are because of dense breasts, but we also just need to think about how we even identify women to come in for mammography. And that's always been a challenging aspect of screening in young women. In older women, again, mammography in particular does really well in older women and in postmenopausal women because the breasts are less dense. And also there is a role for clinical breast exam. And so just to mention in India, because there's been a number of important studies as well as a trial that's been ongoing to think about how in a population to introduce more broadly clinical breast exam, because that also can have an important role in shifting the stage and detecting cancers earlier. And a lot of that is being done by community health workers. And of course, there's many screening tools, mammogram, ultrasound, MRI, that would be a really important tools to use. It's just trying to understand which people, which women to identify them earlier to shift the stage. So again, in India, there's been a number of important studies. There's a large randomized clinical trial that's ongoing that community health workers play a really essential role in helping to raise awareness, but also to do clinical health exams. And so just this past month, there was a review of all of the work that community health workers have done in India and other aspects and other areas of the world. So in terms of then thinking more about screening and thinking about a way forward, given the breast cancer trends that we saw, how can we identify women earlier? And in particular, how can we identify women when we know that mammography is less sensitive, when they're very young and their breasts are dense? Is there a role for genomic screening? There was a really interesting cost-benefit analysis published over the past year, looking at thinking about doing population-based BRCA1 testing. And as these costs for genomic screening go down, that may be possible even in very large countries like India. And again, as Ravina said so beautifully at the very beginning, the importance of awareness of women's health, awareness of breast health, and the importance of research and prevention and thinking about what's been driving these trends, and certainly to think about environmental drivers that could be explaining these trends, which could not be explained by genetics alone.
Thank you, Professor Terry. Our final speaker for today's session is Dr. Sumeet Shah. Dr. Sumeet Shah is a surgical oncologist based in Mumbai. He specializes in the surgical management of breast and gynecological cancers and currently runs his own clinic at Silverline Oncocare. He is affiliated to several major hospitals across Mumbai where he operates on breast cancer patients. Dr. Shah runs one of the most popular Indian sites on breast cancer and also runs the only existing active online forum for Indian breast cancer patients. He is also affiliated to an NGO, the Pink Initiative. Over to you, Dr. Shah.
Hi. Thank you very much for inviting me for this presentation. It's a pleasure to be with you all. So I have divided my discussion today into three parts. First of all, I'm going to discuss the numbers which Dr. Mary Beth appropriately mentioned just in the last presentation. The second point, I'll see what is the impact of COVID-19, a little bit of personal experience. And the third, what do we do going ahead about that? So I'll quickly run through the numbers once, the real and harsh truth that we are facing in India. Number one, breast cancer is the most common cancer in women in India. And initially it was only in cities, but now as well as it is in rural areas. Second is breast cancer is the most common cancer in India, males and females combined. This means that even if we were to combine all particular cancers related to males, still the number of breast cancer is higher in females than any other cancer in males. And breast cancer is the commonest cancer in women in India in all age groups about 25. So I'll just show a few charts quickly and I'll point out what I'm trying to show. Now, this chart is from one recent publication in the NCRP, which is the National Cancer Registry Program. What I've see North, East, West, and South, they are just showing the different cities in India where, and you can look at the percentage of breast cancer as compared to the total in women. You will find that most of them are in the range of say 27, 30, 24, 31, 33, like that. So basically it means that 1/3 of all cancers in women are breast cancers. Now, these charts are from Globocan. I have 3 with me for the year 2008, for the year 2012, and the most recent being the year 2018. So in this chart, we can see this is 2008. This chrome color is cervical cancer and this pink color is breast cancer. In 2008, cervical cancer, cervix, cancer of the cervix was the most common one, followed by breast. About this is incidence, the number of cancers estimated for that particular year, 1,15,000. Then we go to 2012, breast cancer overtook cervical cancer. In fact, the numbers of cervical cancer started reducing and breast cancer went on increasing. And now we see this is the most recent one, where the breast cancer has gone up to 1,62,000 reported cases for the year, estimated cases for 2018. And cervical cancer has gone below 1 lakh. So you see the proportion of breast cancer is rapidly rising as compared to all other cancers. And now I would like you to have a look at this mortality, the estimated number of deaths in the year 2018. India lost about 87,000 women to breast cancer for the year 2018, and that is the second highest in the world. This number is even much higher. If I'm not mistaken, the number for the same year for the United States was around 44,000. Though the incidence of cancer, breast cancer in US was in the range of 240,000. So roughly in the US, for every 6 women detected with breast cancer, 1 dies of it. For China, roughly for every 4 women detected with breast cancer, 1 dies of it. And for India, roughly for every 2 women detected with breast cancer, 1 dies of it. We can see the ratio. This is the numbers detected in the year 2018, 1,62,000. And this is the numbers that were, the death rate. Of course, this doesn't mean that of those 162, this many died, but the ratio just gives us a rough idea of how things are going. And one more thing which was little disturbing, this is from the report of the National Cancer Registry Program. In fact, Globocan, the arm of WHO, gets its data from this only, the National Cancer Registry Program. They have given here in breast cancer in females, they have graded that according to the stage, localized, loco-regional, and distant. Localized means it's a very early stage. Loco-regional means it's a little advanced stage, but not so advanced. And distant means it's the last stage of cancer. So for most Western nations, if you see this ratio, normally the localized one amounts for 60-70%, little advanced amounts for 10-15%, and last stage for about 10%. Whereas India, it's the reverse. You see early stage is about 29% only, whereas 57% come in a fairly advanced stage. This is pretty disturbing. I would definitely want to focus on this statistic. And this is the last picture slide which I'm going to show you. So this is from the same National Cancer Registry Program which I had just shown you. This is the projected number of incidence cases by sites of cancer. I know it's too much of a populated chart, but let us just see. See, these are the cancer in males, these are the cancers in females, and these are the various sites. If we see any cancer, say for example mouth, oral cancers are pretty common in India because of the habit of chewing tobacco. So you see 52,000, 54, maybe 57 is expected. Tongue cancer is 44, maybe rectum is 24, stomach is 36. But look what is happening at breast cancer, the estimated. It is 1,90,000, 1,95,000, and in future it is predicted to cost 2,32,000. So you see, if you compare the number of breast cancer to any other cancer here, you will realize the difference. So the idea of showing this was what Dr. Mary had also mentioned, that incidence, the chance that a lady will have a breast cancer is, well, we can reduce it by doing certain lifestyle changes, but that's all about that we can do. If it has to happen, it will just happen. It's not in our hands. But what is definitely in our hands is reduction in mortality. We can bring the death rate down if we catch it early. That is where the fight for India lies. So on the background of this, let me give a little bit of idea of what happened during the times of COVID-19. Dr. Rao painted a very clear picture of what had happened in New York at that time. The difference in what happened in the US and what happened in India during the COVID-19 is that the peak of India has been very slow to rise. Of course, it is still rising. We have not even attained the peak. Whereas in cities like New York and all, there was a very, very sudden spurt, overburdening the healthcare resources. So here also, of course, the healthcare resources are sparse. I'm talking about Mumbai. It's not that we have not, but because it was a very slow rise, there were many hospitals which still went on conducting cancer surgeries and not many had to be delayed. So now let us see what, this is from my personal experience, because statistics for this COVID-19 period are not easily available. So I had discussion with my colleague, my team, where we run the breast clinic, where my colleague, Dr. Shilpalar, is a radiologist, Dr. Ashish Joshi, medical oncologist, and we have a genetic counselor, and of course a few others also. I'm going to discuss the type of OPD visitors. We have three kinds of visitors. One is the symptomatic patients, somebody who has just had some symptom, maybe a newly detected lump or maybe some other symptom, maybe pain, it could be nipple discharge, anything. The second type of visitors to the breast clinic are breast cancer survivors. These have already finished the breast cancer treatment and they come regularly for follow-up, usually every 6 months or maybe every year. And third is those who have come for screening. Nowadays, we are finding women who are coming for screening. There are no symptoms as such, but they do come for checkup because they've read on the net and they're a little aware of the breast cancer. So let us see how it went. The patient flow in March and in April, you might be aware that there was a massive lockdown all over India in the end of March and April. During that time, we were functioning. I'm affiliated to a few hospitals. One of them is a cancer center, and being a cancer center, it was not converted into a COVID hospital. So we were available. So we realized that in the end of March and almost for the whole of April 2020, only a few symptomatic patients showed up, which is not even 10% of what we would have expected in a routine time. There was no visits at all by survivors at all, or even those for routine screening. So only these few symptomatic patients we did work up, and with appropriate precautions, we did operate. Then from May to July, May 2020 to July 2020, there was a gradual increase in the numbers of symptomatic women. By symptomatic, I again mean that those who had newly detected lumps or some breast symptoms. But the other two classes, there was barely an increase in the number of survivors because they were afraid. Many of them would call me that this is how, should I come or not? And there was absolutely no flow for women who would come for screening. By August and September, now we are seeing near normal expected numbers of those patients who would come with symptoms. But the most important point, significant delay was very much evident, which I'm going to discuss now. Slow increase in the number of survivors, like now those who have finished the treatment and on routine follow-up, they have started coming now. But there is still hardly any uptick in the women for screening. And this is what worries me. Screening is one thing which is extremely essential if we have to get the death rate down from the breast cancer. So 2 points. There was a definite delay in presentation by many women who had noticed new lumps or other symptoms. And this delay was due to fear of COVID or due to COVID-related inconveniences because the roads were closed, there would be police checkpoints everywhere and all. And also definite significant reduction in numbers of women who would come for screening of breast cancers, both to a clinician and to radiology centers. Even now, the numbers have not come back to pre-COVID times. So at the end of it, during the COVID times, there were fewer early breast cancers, whereas we saw more of locally advanced cancers, where because of delay, the cancer advanced to such a state that we could not operate first and we had to give chemotherapy. And this was clearly because of COVID fear, because when we asked the patient, since when did you notice these symptoms or these lumps, they would say 3 months, 4 months and all. And, we would ask, why didn't you come earlier? Of course, it was due to COVID. So now I'm going to refer one case. I'll quickly run through it because the image which I'm going to show may not be comfortable for many to see. So this 65-year-old lady, she first felt a lump in the end of February 2020, just about when COVID was beginning. She took some painkillers as usual. And unfortunately, many Indian women or just Indian population in general ignore symptoms for a while. Not many are well educated about symptoms of breast cancer. Lockdown started in March 2020, third week, and so that lady never came. Then she waited till May 2020. Lump increased fairly much in size. but still she was afraid. So she could contact some homeopathic practitioner and she took some alternate treatment. Didn't matter. Finally, the tumor burst and there was a lot of pus discharge in the end of August. That's when that finally she presented to me. So when she came, the whole tumor had burst and there was pus. We gave her antibiotic and it settled, but this was roughly how it would look. You can see the whole tumor has ulcerated through the skin and it has come out. So, and the whole area, even the skin was involved here. You can see how difficult situation it was. This after I gave antibiotic. I could myself not stand before that time when the pus was discharging. It was foul smelling. So well, that was it. She did get operated. Now the whole mass is out. But then what can be done in this COVID times and in other times is general? COVID-19 is likely to remain with us for some time. But what India needs is a real mass education of breast cancer awareness, and we need to target the media for it. Because Indian people love everything which comes on media. So media, FM channels, social media, newspapers, and now October, being the Breast Cancer Awareness Month, is the right time to hit the hammer, catchy slogans, posters, etc. And we do wish that a lot of other organizations pay attention to it, a lot of NGOs, and collectively we can make a difference. Of course, we also need to, people tend to be afraid of COVID. So all media where we are giving awareness, we can always carry some instructions on safety during COVID, but the cancer part doesn't need to wait. And we should provide safe environment, physical distancing and time spacing at the mammography centers to make them comfortable and come more and more for the mammography part of it. So well, the day most of my patients tell me that they felt the lump for the first time since 3 to 4 days. This is the general word I'm looking for, instead of 3 to 4 months now. That is the day I'll believe that India has achieved its target in early detection. And I've been reading a lot of US data, the SEER database. I read about the awareness programs which started way back in 1980s, So if the US example is anything to go by, this day which I'm waiting for is at least 15 to 20 years away, if not more. And a lot of work needs to be done in terms of awareness and getting people to screen. So that's about it. Thank you very much.
We'll now have the question and answer session moderated by Dr. Ravina Agarwal.
Thank you so much to all our panelists. And, I'm going to ask if I'll start with a couple of questions myself and then turn to the questions that we've been receiving from our participants, our audience members. So I'll start with you, Dr. Shah, because you gave us, your own aspiration and hope for reaching numbers that are vastly reduced in terms of breast cancer. Could you talk a little bit about your online platform? What motivated you to start that, and what kind of questions and what kind of what kind of engagement you received with that? I'm asking also because is breast cancer continuing to be stigmatized in India? Is there any fear that women have due to to sharing their pain with families, or is it just that they delay seeking healthcare for themselves?
Yeah, so you asked me what motivated me to start. I happen to be running the website breastcancerindia.net since 2010. It is one of the few websites which gives authentic information about breast cancer in India. I tried to source from a lot of places, NCRP, Globocan and all, at least compile that. And I've had a fairly good response. We do get emails time and again from people. The reason I started was I was in Tata Memorial Hospital. You may have heard the name. It's one of the largest cancer centers in Asia. I was working there in my residency training for surgical oncology, and then later I was a lecturer there. What I used to see and what used to pain me is breast cancer is one cancer which can definitely be caught early. But seeing the number of people coming in late stages, I used to analyze the reasons. And I saw that few common things which I found was, one is, a strong trend for alternate treatment. People in India have a strong belief in alternate treatment, and they feel that anything and everything can be cured. I have nothing against it. I myself accept alternate treatment for certain, but it's not for cancers. So I used to see delays due to alternate treatment. Then I used to see delays due to delays in due to doctors also. There are many, doctors who were not aware of breast cancer and all, and people the patients presented on time, but there was a delay due to doctor's part who was not well. So I felt that there was some need to educate the people that you can very well come on time. And that's when I started that initiative, the Breast Cancer India website. And we also started, we have an online forum, which is the only existing online breast cancer forum for breast cancer patients in India. We have by now 2,500 members. And there was a lot of engagement. So, well, this did help. We do get queries time and again related to breast cancer, and it only educates me more and more that a lot of work needs to be done. And you asked me about the stigma. There definitely still is stigma. See, I stay in the city of Mumbai, where it's being a metropolitan city is a different scene altogether. But yes, even in a city like Mumbai, even in the place where I practice, I still see that there is definitely some amount of stigma. People are not willing to disclose about the illness to their near and dear ones, or even in the building. When I request them that would you want to join my survivor group, wherein you can talk about this and motivate many others who have newly diagnosed. Many of them are afraid. We don't want to reveal our identity and all. So the stigma still remains. I mean, it's less. Mumbai, definitely it's less, but I can assure you that all over India, if we were to see, yeah, it's still there.
Thank you. Just continuing on that conversation, what are some of the barriers that, Dr. Rao and Dr. Terry, you observed in your work, either from New York when you're dealing with, different populations, or you're dealing with women in general? Are there some barriers in identifying or coming or seeking healthcare, and working with communities that are low-income communities? What are some of the challenges that you have to deal with when it comes to screening? So if you could comment on that, let's start with Dr. Rao and we'll come to Dr. Terry.
Yeah, so we know that when we look at national level data, only about 80% of the women who are eligible and have insurance come in for screening. So these are people who you would theoretically say have no reason not to get screening, and for whatever reasons they choose not to. Generally, it's a matter of time, or to some extent nowadays it's a bit of confusion about should you start at 40, should you start at 50, should you get it every year, every other year. That's kind of muddied the conversation. The other thing is during my time at MD Anderson, we looked at our Indian population there. So this was an Asian Indian population in Houston, and what we found was that a great majority of those patients who were coming in due to palpable lesions. So they felt something and had not undergone screening. So it was interesting to me that some of the lack of interest or whatever it is in screening seems to carry over in these immigrant populations, despite being in a totally different setting.
Thank you, Dr. Shao, for that very important presentation and all your work. I would just echo that it has been, I guess, a challenge, particularly with the complexity of knowing what to do with women who are younger. And so in particular, screening guidelines have changed quite a bit in the US recently, which has made, I guess, for some confusion. I think in particular, one challenge that we have all the world around is trying to identify women who are needing screening more. So there is a lot of conversation about moving from age-based guidelines to risk-based guidelines. And so what that will mean for everyone is that we need a better way of identifying women who are at higher risk. And in particular, the young women in our own communities who suffer the most are the young women who have triple negative breast cancer and who don't have a family history, so they don't have the mechanism of going for earlier screening because of the family history. So as these trends increase in young women, that means more and more this family history way of identifying women isn't going to be sufficient to capture all the young high-risk women. So I think that's been a challenge in our communities too, is to find women early enough before they have palpable lesions.
You talked about working with the community health workers, and I wonder, what specifically can the community health workers do? Do they, for example, where does self-examination fit in? I know that people are quite apprehensive sometimes to try self-examination or to rely on it because they don't know if they're doing it right. Is this a role that community health workers could play, or are there other types of roles that community health workers play that you could outline?
So the data on self-breast exam has been very mixed and not supporting a real big benefit. I'll let Dr. Rao and Dr. Shah also talk about that as medical providers. But healthcare workers and people who are trained in giving what would be the equivalent of a clinical breast exam in an office, the data there look a lot more promising. So I think the challenge is really to make sure that it's done correctly. But I'll let the medical doctors answer that. Thank you.
There is a role for clinical breast exam. I think it has to be taught to some extent, and I think that's the issue, is that if it's not taught and women aren't to some extent instructed on what may be normal versus not, that's when the confusion starts, as far as coming in for things that are not normal or ignoring things that shouldn't be ignored. And we get a lot of patients who come in because they feel pain, and there's always this concern that pain is a breast cancer symptom, but if they have a mass that doesn't hurt, that's much more worrisome, as we all know, but they don't come in for that issue. So I think it has to be done as some sort of educational initiative, and can't be, I agree with Dr. Terry, that if it's just done, if we just say go do clinical breast exams, that's not going to get us where we need to be.
Dr. Shah?
Yeah, I would agree that for a country like India, that will definitely have some role. Though, of course, the final aim is to get people to do more and more mammography screening. But even a breast examination, I've seen that people do falter. So it's like give a man a fish a day and he will eat, whereas teach a man fishing and he will eat for a lifetime. So if a community health worker teaches a little bit of breast examination to people there, at least a female community health worker, they'll be comfortable. And at least if they teach that examination, then we are likely to have at least some amount of people coming a little earlier. So that would definitely help to some extent, no doubt. And then we can go to the next step and try to motivate them and get for mammography also.
Okay. I want to talk to you about the financials of this. What kind of investments are we seeing from city governments or from the public health or from health, our health treasury in some ways devoted to breast cancer and to screenings? Do we find more investments in this or less?
Let's divide this into two parts. Finances from the government side, where free screening centers or whatever subsidized screening centers may be available for people in India, and the private setups. So as far as I'm aware, there is not much of an initiative now from the government side. I don't see that there are many free centers. However, one thing the government has definitely done in India is they have replicated the model of Tata Memorial Center. Earlier, there was only one main hospital in India, Tata Memorial, a few others, one in Chennai, one in Ahmedabad, one in, say, Delhi and all that. But now they are on the way to create 16 centers like Tata Memorial all over India. Some 3-4 have already been inaugurated, one at Benares and all. So they are doing that bit, but that is a cancer center in general. When we are talking of screening or mammography or related to breast cancer in particular, presently there is not much of a movement. But in bigger cities, there are lots and lots of private centers, and people suddenly come out for mammography in the month of October because the newspaper, media, everything is laden. There are forwards related to breast cancer. And once October goes, people will again forget about it. So, we need a round-the-year program. That's why I was targeting about that radio, because I feel in all the rural people, the one thing that they all listen to is radio, All India radio, FM channels is common. So and it doesn't cost. How much does it cost to put a radio at 10, 15 seconds, day in and day out, if we keep on hammering, do this, do this, do this, do this, do this. So they will at least remember. And next time when they go for a bath, they will remember, okay, yeah. So I guess that's what we should be doing.
Thank you. Dr. Rao, I wanted to ask you, from the New York perspective, do you find, was there like a turning point? Was there, government rules, government investment, that you could talk about?
So I think New York, to some extent, has been on the forefront of this. They had the New York health insurance study that was randomizing patients to mammography versus not. And they do have a lot of investment in navigators and patients and people who are able to communicate with different portions of the community to be able to get them in for screening mammography.
One of the questions that's coming up is, does having, if you've gotten chemotherapy or radiation, or if you've, are there any specific guidelines where breast cancer patients can protect themselves from exposure to coronavirus?
Yeah, so there have been, I saw some of those. So there have been several guidelines that have been put together by our different oncologic professional societies. So the American Society of Breast Surgeons, the ASCO guidelines are all out there. What we typically do is that if a patient gets diagnosed with COVID, and we did have several, I believe there were 30 patients, we have a little case series, who got diagnosed with COVID during their treatments for breast cancer. And what we did was that we would halt their treatment for 2 weeks, whether that was surgery or chemotherapy, ask them to quarantine during that 2-week time period, and then come back and get a negative test. Once they tested negative, then we were able to reinitiate whatever treatment they had been on the schedule for. So a short delay to be able to get them back on track. And there were no adverse outcomes from that. And this was also for people who lived with someone who got diagnosed with COVID. We would have to stop their treatments.
Dr. Terry, you've been working on looking at environmental exposures and environmental drivers. Could you talk about the importance of that kind of research in dealing with breast cancer?
Sure. And I guess I was just going to add to your last question, too, about the cost effectiveness. Screening in particular, really, because it does change this, the stage of presentation, has tremendous benefit, particularly for young women who are diagnosed at a time in their life where they're caring for either the generation above or below them. So, the cost effectiveness has been shown for screening, and now more and more for genomic screening. So that may be a way to go too in the future, particularly as the cost of BRCA1 testing goes down. But very quickly, in terms of thinking about environmental drivers, here we've learned a lot too from COVID, because the presentation of worse outcomes after diagnosis for COVID have been in the communities that suffer the most from air pollution and other environmental contaminants. So over and beyond individual conditions, like asthma and heart disease and things like that, that they've shown clustering of worse outcomes after COVID because of environmental pollution. And so this is something that, really COVID has revealed so many things about our healthcare systems and about individual susceptibility, but also about interactions between macro exposures and the macro environment and our own individual susceptibility. So, our own research, which we're very excited to partner with you, has been focused on endocrine disrupting chemicals and the influence that they have on breast cancer risk. And more we see with breast cancer outcomes after diagnosis, which makes a lot of sense given, the endocrine treatment and therapies. So thank you for that question.
Thank you so much, Professor Terry Rao and Dr. Shah. This is a really very important issue, and this is not going to be the last time that we engage with it at all. We hope to concertedly work together in raising awareness about various issues related to cancer in general and to breast cancer in particular. And, our experts have pointed to the importance of various forms of screening, whether it's a genomic, diagnosis for population risk, assessing population risk, whether it's looking at, communicating with community health workers in, particularly in areas where there's, less access to clinical care, and working with community health workers and getting, appropriate means of understanding issues of breast cancer and diagnosis and self-diagnosis as well. And then also the importance of whether online through telemedicine or offline, actually visiting a clinic, both, when one is symptomatic or when is, for routine screenings. These are extremely crucial and important for us to be able to deal with not only the pandemic that is coronavirus, but also the pandemic that is breast cancer. And I think it's important that while we are dealing with this, and sometimes, other morbidities tend to get sidelined when we're dealing with something that we've turned our attention to. But I think 6 to 7 months down the line, we're back into reflecting on what lessons we can learn from the coronavirus, also in treating other pandemics, of which breast cancer is one. So thank you so much for this very, very important panel. And I look forward, to seeing our audiences at other events, particularly being with us throughout the cancer series, Screenings That Save. And thank you once again to Dr. Rao, Dr. Terry, and Dr. Shah for joining us.